start out with the historical background to transgender as a concept. And I speak of these three individuals as the trio from hell. We have Alford Kinsey, who was an entomologist. That is, he studied insect and insect behavior. And somehow, as a sidebar, as a sort of adjunct part of his clinical teaching responsibility, he was asked to teach the undergraduate medical students at his college all about sex and marriage, something that he was himself not terribly well versed and had to do a little digging and research. So he jumped from that to being an expert, internationally renowned in his own mind, and established the Kinsey Institute of Research, which is responsible for, as it was alluded to yesterday, the change in philosophy of accepting types of sexual behaviors in human beings as norms. The next person is Dr. John Money, and I happen to know him personally, and we'll go into that in a little bit. He was a psychologist trained at Harvard who came to Johns Hopkins in 1951. And he sidled up next to Dr. Lawson Wilkins, who was essentially the first pediatric endocrinologist in the North American continent. And he knew that Dr. Wilkins was involved in clinical research of hormones and the actions of those hormones on the developing fetus in utero, and how sexual anatomy came to be defined in its appearance based on the effect of hormones on the developing fetus. Dr. Lawson Wilkins had a staff of individuals who developed the concept of treating cortisol deficiency with hydrocortisone for the very first time in the 1950s and saved the lives of these children. He also, the division, because of the effects of the hormones on the developing genitalia, there were patients referred to Johns Hopkins from around the world who had been babies born with an ambiguity of the appearance of their genital structures, and Dr. Money thought that would be a great time for him to step in and do some experimentation on some outcomes. He actually quoted himself in a book that was in memory of Dr. Wilkins, that he believed himself to be as good as any pediatric endocrinologist, just on the basis of the fact that he followed the endocrinologists around, even though he was a PhD in psychology. And lastly, in this trio is Dr. Harry Benjamin, who was a family practice doc who practiced in New York City, but when winters would come, he would move to San Francisco for a couple months, and he was the doctor who prescribed the hormones for Christine Jorgensen, for that person's physical change from the appearance of a man into the appearance of a woman. General medical practitioners, as I said, he had no background in endocrinology. So here is a picture of my fellowship group, and there I am, a little more hair back in the day. And this is Dr. John Money, and what he looked like. First time I saw him as a fellow, he had straggly brown hair, came in the same dirty corduroy coat, day in and day out. He looked like somebody who'd come out of a park bench, having slept there all night, and come in and give us some lectures and seminars. He made it a purpose to take any, particularly female fellows, and those that had any devout religious feelings, and he offended them in any possible way he could by making jokes, by calling out the folly of their own particular religious beliefs. So this was how Dr. Money intimidated the students and fellows. He introduced the term gender as a psychological construct, and beforehand, gender was a linguistic term. The languages, the Romance languages, had female and male nouns and pronouns that were used. And so that was where the term gender was strictly a linguistic term, but he decided it was the internal sense of who you were sexually. So your gender was how you perceived yourself internally, and your sex was what you were biologically based as. And he did not believe it was actually a inborn concept. It could be manipulated by society, and he was the one that was going to manipulate these young babies who had ambiguous genitalia and send them on a track of either being raised as female or male based on what he thought was the best. So he created a group called the Psychohormonal Group, and he came. There was a baby that came from Boston, and I was. My glasses are bothering me here. Money trained in Boston, decided he wanted to come to Hopkins because of the wealth of patient population. And as I said, Hopkins was the epicenter because of the kids with the ambiguous genitalia. He had an adult transsexual program. He had about 12 patients that he took as adults, brought them in, and they desired to be the opposite sex, and so he decided he could help them change to the opposite sex, which we know, of course, is biologically impossible. But he would bring the patients in, he would evaluate them, he'd make sure that they were mentally stable. He made sure that they had a bank account of $2,000, which could be used to bail them out of jail, in case that happened along the way with their new persona on the street soliciting sex. And he made sure that they were stable in that hormone environment for 2 years, and at that point in time, they could be subjected to surgery if they wished and have their genitals altered to appear as if they were the opposite sex. So the gynecology department developed the technologies to create a pseudo-vagina and a false or a fake penis to put on these individuals who wished to appear the opposite sex. And that technology was then actually micronized and transferred for genital reconstructive surgery for the babies who had ambiguous genitalia as well. So this was one of his patients, and we in the pediatric endocrine division were charged with following the adult transsexual patients, as they were called, because the adult endocrine department wanted nothing to do with this folly. And Dr. Money was able to convince the pediatric endocrine division to follow these adults and help them in their adult life. And this was Dontrella, and you can kind of guess what her day job is. His scientific protocols were, I have an idea. That's the basis of science. I have an idea. Let's do something to this patient and see how things work out. Now, that's not ethical medical practice in this day and age, but this was in the 70s and the early 80s, before protection of human subjects came about. He directed interviews with the pediatric patients. He liked any patient that either had ambiguous genitalia or early puberty. And he would interview the patients repeatedly, and these were transcribed into paper copies that were in the endocrine patient's record, so we knew verbatim exactly what questions were asked. He taught children, male children, how to masturbate. He asked how frequently they masturbated, and when the kid did not understand what masturbation was, he would demonstrate it with a pencil. And then the next time the child came back, the child was masturbating at least 2 or 3 times per day because he'd been instructed on how to do so by Dr. Money. This would be scandalous sexual abuse in this day and age, but back then he got away with it. So there was a tragic case of twin boys who were born, and one of them had his penis burnt off accidentally during a botched circumcision. It was one of the Reimer twin boys. And Dr. Money immediately contacted the hospital and had the boy transferred in, and they looked at some reconstructive things that they could do to the remaining stump of the penis to make it go away, to try to create a pseudo-vagina and some labia out of the scrotum. And this young boy was raised as a girl from young child infancy onward. The boy did not know. His twin brother did not know. The boy had severe depression and anxiety during his whole childhood, and his independent clinical psychologist said, I'm going to go against Dr. Money's request, and I want this boy to know his biologic sex. And when that boy was told, when he was in his late 8, 9 years of age, that he was a biologic boy, he burst into tears and said, I knew this all along. I knew there was something definitely wrong. Money had taken these 2 boys, the boy and his sister, and had them do sexual play in the bathtub when they were youngsters, so that they would know about the reason for their genitalia and what the genitalia were supposed to do. Again, would be thrown in jail in this day and age, but got away with it back then. The sad thing about this young man is that when he lived as a man, he had some reconstructive surgery on his penile stump so that he could have some sort of effective intercourse with his new bride. And they adopted children. Since his testicles were gone, he had no fertility to offer into the equation. And he took his life at age 23 from severe depression. His twin brother died a year before from drug abuse, chronic drug abuse because he had learned the story and he couldn't deal with it either. So that was the legacy of John Money at Johns Hopkins, and when this happened, his program was shut down by the new chairman of the psychiatry department, Dr. Paul McHugh, who is an emeritus professor there to this day. My personal interaction with Dr. John Money was with one patient that came down from Buffalo at 6 months of age for evaluation of what was called a micropenis, where the penis is particularly small. And this child had a penis that was small, but also had 2 palpable testes in the scrotum. So we knew that this child was not some sort of hormonal interplay. It had to do with the finishing off, if you will, of the genitalia in the last trimester of birth, and that didn't happen for this boy. So my mentor on the faculty and I put together a protocol which was standardized to treat this boy with human chorionic gonadotropin, which would stimulate the testicles. If the testicles could respond, we could see that response by changes of tissue, and we could also measure testosterone levels and then look at the tissue response and verify that this boy should remain a boy because he is a boy, and at puberty we can induce this process artificially with gonadotropins that simulate what the pituitary would naturally do, and this boy would be a fertile adult the way God intended him to be. So that was what we did. Dr. Money was out of town, ostensibly, and so we didn't have an interview with his psychohormonal group, but what we didn't know is Money got back early, found this patient on the list, saw the diagnosis, and interviewed this family unbeknownst to us before they returned to Buffalo, where he was supposed to have this series of injections given by their primary care doctor. 6 months later, we brought the boy down to see what kind of response we had. And in comes a baby stroller with a little girl in a white eyelet bonnet and a pink dress, and mom and grandma. And mom is talking about the new little girl, Tabitha, and their family, and we were expecting to see David return. And it said Tabitha came in. And grandma kind of pulled us aside and said, Is this the right thing to do? It just doesn't seem right to me. I mean, he looks like a boy. So we examined him, and his genitalia had grown to a normal newborn size. He responded. His testosterone levels were where they should be. We had an intact male who had had an incident in his last trimester of pregnancy that prevented him from finishing off the genital development. But he was not ambiguous, and he was biologically a boy. And so Tabitha turned back into David at that visit. And John Money was chastised and told to forever stay away from pediatric endocrine patients that time forward. So that's how I learned about what Dr. John Money was, and he was one of the 3 individuals here who started the sexual revolution in the United States and for all intents and purposes in the world. So if you look at transgender clinical services from the 1970s to 2006, it was almost all patients in the Netherlands where these protocols were developed to take adult patients, not pediatric patients, adult patients, and allow them to try to transform their bodies from the appearance of one sex to the appearance of the other. In Toronto, Dr. Kenneth Zucker dealt with children who came to his clinic starting in the 1980s, and they were children who came with the idea that they were confused about their identity as a male or a female, and were sort of play acting in the opposite sex roles. And these were the first children that were evaluated at any length, and they were psychologically evaluated, as were every member of their families. And Dr. Zucker handheld them and walked them through this process, got them through puberty, and by the end of his tenure in 2013, had treated 560 children. That's from 1980 to 2013, 560 patients. That's all that came to him from around the world to go through that process. And with his intervention, the kids went through puberty, and upwards of 80 to 90% of them re-identified their gender identity, and it was in alignment with their biologic sex. That would be called a dramatic cure in medicine. If you can do 80 to 90% restoration of mental health and physical health, you have done one heck of a job. It should be applauded. Okay, so that's the reality of what's called watch and wait therapy. It's not watching and waiting. It's watching and intervening and supporting and giving these families and the kids the right information about what their design and plan should be. Now, in Boston, Dr. Norman Spack is a pediatric endocrinologist, and he went over and looked at what was going on in the Netherlands. And in about 2000, the Netherlands decided, well, if we're doing all this transformation of the physical bodies on these patients in adults, we might apply it carefully to a population of children who, as very young children, feel that they're born in the wrong body. In the Dutch protocol, these kids, again, were very, very strictly handled in terms of their mental health. Evaluations were done, and they carefully chose the small number of patients to try a sort of John Money type of experiment of saying, let's go ahead and interrupt puberty when it starts, and then let the child decide, are they still with us? And a lot of the kids in that initial protocol decided that they were fine and dandy as they were biologically meant to be and didn't go any further. So that was called a pause, allowing the child to continue in mental health therapy. And if this did not make a change when the child was well into the age of what would be normally puberty, and they still persisted, then they were offered what were called cross-sex hormones. And their physical bodies would change in response to that. And then they would be essentially sent into the adult world for the option of some surgical intervention. But no children had any surgical procedures done to them in the Dutch protocol, as it was called. This was a small number of patients, upwards of 60 or 70 that traversed through this program back from 2000 up to 2006. Dr. Spack visits the Netherlands. He has an agenda in his head. He must have had an agenda. He came back and said, I want this in the United States. We're going to do that here. So he was the first official transgender clinic operator in the United States, and he came back in 2007. That's how many clinics there were just that short time ago. Okay? So keep that map in mind, because we're going to look at another one coming up. Now let's talk a little bit about the background of international support for taking somebody of one biologic sex and making them appear to be the opposite sex. The Harry Benjamin Society was started when Harry Benjamin died, and Kinsey and Money got their heads together and said, we want to have this adult protocol, have a place to live and to be developed and refined. And we want to be a resource. This is pre-internet, so everything had to be by mail or telephone, where they would have a network around the world of physicians who would be willing to do this. The mainstream practitioners of endocrinology and gynecologic surgery and urologic surgery shunned this completely. They looked at it as a terrible folly that should not happen. This was what was going on up until 2007. Nobody thought that this was a good idea. There was no consensus whatsoever that this should happen to anybody, let alone children. The Benjamin Society membership requirements said you had to be alive, you had to have an interest in transgenderism, and you had to pay dues. That was it. So the Harry Benjamin Society disappears, and this lovely new society called the World Professional Association of Transgender Health is born from that caterpillar. Same group of people, very professional sounding name. WPATH is not happy with the major medical literature, so it does not reference that. Zucker proved that 80 to 98% of children and adolescents with gender identity disorder, as he termed it, he was the head of the DSM-5 criteria planning committee on gender issues. And he created the term gender identity disorder for the fourth version of that document. And that held until the fifth version. But the vast majority of them in his patient population desisted. It's called desistance. It's a dirty word for the crowd who doesn't like that term. So a study in Sweden reveals that suicide rate of adults who progressed into adulthood with affirming therapies, both medical and surgical, had a 20-fold increase of completed suicides, not thinking they want to kill themselves, not having an idea that they make an attempt to do so to make a statement about their poor mental health and their anguish, but actually taking their lives and dying from it. 20-fold increase over the general population of Sweden. Now, this study has been criticized because they didn't have a study that showed no treatment with surgery or medicine, comparing it to medicine treatment alone, comparing it to medical and surgical. So they really didn't have any reference control group. But the one thing about this study that burns everybody up on the other side, it's a population study. It's retrospective. They went back through the medical records, but that was every single transgender person in the country of Sweden. Whether or not they wanted their data included or not, the health system over there knows everybody from cradle to grave. So they had all the data on everybody. That's powerful data, okay? You compare that to today's studies that get published every other month on convenience sampling from samples from the Trevor Project group, who basically have a bias already based on their internet presence of recruiting individuals that want to say something. Not patients who died. They don't say very many things when they're dead. Not patients who are morbidly afraid of coming out to let people know how unhappy they are because they're attacked viciously by the transgender affirmation crowd if they raise their hand and say, I did the wrong thing. So these convenience samples do not sample the population of transgender individuals. They sample a very convenient, biased group, and it doesn't account for all the things you need to look at for causation. It shows association at best, but never causation. And there's a rule in science that you do not publish any study that is based on a convenience sample because it's invalid. It does not prove anything. And unfortunately, the editors of medical journals in the world today, and particularly in the US, bring in these convenience samples and just publish them month after month in what used to be the most reputable journals. So WPATH creates its own bibliography and on its site, about 120 references that they have. And when you go through those references one by one and pay attention to them, what we call vetting a reference, you find that they're anecdotal case studies. Hi, my name was Lily. I used to be Ben. I'm happy. I'm the happiest person on the planet. There you go. See, report of success. All right? And that kind of anecdotal stuff is riddled throughout there. They also write articles with very poor reference in journals, what we call throwaway journals. And I don't mean to, they have a purpose. They get to the general population of practitioners in a certain specialty area, but they don't have to vet references. They're not peer-reviewed. And they make statements that necessarily are not true. And then that's picked up as a reference to prove the very same statement in another journal several months later, and that journal is used as a reference for the next one, and they just reference. So when you go back, you find out the real core of true science is this thin and not valid. There are no controls that they have. There's no controlled study moving forward, and that's the one thing that we hear. Well, it would be, you're sentencing these children to death if you don't treat them. You can't have a control group that you don't treat with medicine and surgery. They'll all die. You're going to sentence them to death. So we can't have a control group. Well, then you can't tell that what you're doing makes any difference. And when you do the studies that they do and say, look at the mental health on this, the untreated ones in the most recent study have worse mental health than those that were treated. Well, then you look at the baseline and the tables. 50 to 60% of these kids have mental health problems to begin with. Something's wrong there. Does that not signal in the brain that, hey, maybe these people are not happy to begin with. They might have mental health issues to begin with. And when you look at the table at the end, their mental health is exactly the same. The only comparison they make is to the untreated who have more mental health issues. Now, look at the group over here. How come this group starts out with 150 and this untreated group starts out with 10, and at the end of the study you have one patient in the untreated group, and that's statistically significant? That tells you that all untreated people have worse mental health. What happened to the other 9? They dropped out, or they killed themselves. or they just didn't want to, they were fine. They got through some counseling, and they didn't want to be part of the study anymore. So all of this stuff is presented as science, and it's repeated over and over again to legislative bodies who are making laws in states. It is part of the fabric of what Rachel Levine presents, that all the data shows that there is incredible benefit to treat these children. And I hate to call it a treatment, okay? It's an intervention that is harmful. Treatment would suggest that perhaps there's a benefit, and there is no proven benefit. But this is the core of the values of the WPATH organization. They create a peer-reviewed journal called the International Journal of Transgender Health. Well, guess who gets to publish in there? Not me. Anything I would throw there would be completely turned down before it even arrived, just on the basis that it doesn't fit the mantra. So what use is that peer-reviewed journal when it's not reviewed by peers across the whole spectrum of opinions, but just people who have the dogma in their mind? So WPATH is now essentially going to release what they call their 8th version of their standards of care. Let me tell you about standards of care. In medicine, a standard of care is a concept that came from inviting everybody with every opinion who's respected into this room and having them haggle it out with each other until they meet somewhere in the middle and all agree that these principles we can all agree on. Okay? WPATH just has everybody over here that drank the Kool-Aid and doesn't have any other beliefs. And they publish things that they believe in. That is not a standard of care. That's a statement of opinion. But these things are called standards of care, and that side of the issue keeps saying over and over again, standards of care, standards of care, standards of care, so that the news media picks up standards of care. Legislators, governors, federal health officials, standards of care. Doctor, why don't you believe in the standards of care? Aren't you aware of what your professional organizations claim as standards of care? And I'd say, they're not standards of care. I've talked to judges face to face and said, these are not standards of care, these are opinions, and it doesn't hold water. It's not what everyone believes, despite what you hear. So the APA, the American Psychiatric Association, decided that in the 5th edition of the DSM criteria, the Diagnostic Statistic Manual of Mental Health Issues, that they were going to eliminate gender identity disorder as a disorder. Because they said, we did this with same-sex attraction back in the 70s, we need to do this for the transgender community. They cannot be labeled as having any kind of mental disorder because we believe it's not a mental disorder. Well, these are, again, the same WPATH individuals making the rules. Kenneth Zucker chaired that session, and he was pressured under fear of his practice being shut down in Canada by the WPATH activists, that he come up with something that they could live with. So they invented the term gender dysphoria. Now, if you don't have a diagnostic criteria that says this is a disease state, then how can you get health care insurance to cover the processes if it's just cosmesis? You don't like your nose, you want to get a smaller nose, a bigger nose, a taller nose, narrower nose. Insurance does not cover that just because you don't feel like you like your appearance. And that would be what would happen to all these individuals that were going to have surgical procedures and medical treatments. None of it would be covered. And some of these things are, the surgeries are outrageously expensive. Some of the medicine is crazy expensive. Some of it's very cheap. But who's going to pay for it? So by having gender dysphoria, you have a diagnosis that needs attention and can have some treatment. And what are the treatments? All the things you had before, but you didn't label the issue of gender incongruence as a pathology. It's the suffering or the dysphoria that happens because you happen to have that particular condition that is supposed to be innate. And so that's what Dr. Zucker acquiesced and did, and the WPATH terrorist had his clinic shut down anyway. He sued the government of Canada and won 450,000 Canadian dollars in settlement and an apology from the Canadian government. But that was a victory in some sense, but the man's career was clearly, and and all of his reference articles, he was the king of gender identity disorder in anybody's bibliography on the subject, and his name was visibly absent from all the guidelines from that point in time on. So they erased him just like that. Promised him a sanctuary, and then took it out from under them. Now, the favorite thing about the suicide risk is that society, you and I, and society at large, are blamed for causing all of the mental health issues of these inborn, quote-unquote, transgendered individuals. That all of their anxiety and depression is your fault or my fault. And that if we just became tolerant, these individuals would have no mental health issues. And that is absolute bull, okay? The minority stress theory does not hold here. It certainly is not true for the African-American population, which had incredible degree of agony to go through until they were recognized as equal human beings to non-black individuals. They don't have that kind of depression and anxiety in their community. They never did, okay? It's just somehow privileged white folks who are in this transgender community end up having the only one that have stress induced by society. And that's absolutely patently ridiculous. Patently ridiculous. So, back at the ranch here in the United States, Dr. Spack got together after he'd come back from his trip to the Netherlands and started his clinic. And he got a group of adult and pediatric endocrinologists and some non-endocrinologists. There was a guy who was in physical medicine rehab. And they got together a group within the Endocrine Society and called it a special interest group. They recruited like-minded people, and they came up with some guidelines. And they published them in 2009. The Endocrine Society is an academic organization, and they are highly revered. They have about 4 journals which are read internationally and respected. And they completely kept everybody with a contrary opinion on this issue off their committee. So Dr. Zucker, who is the godfather of gender identity disorder, was nowhere to be found on that committee. Dr. Paul McHugh, who is now the emeritus chairman of psychiatry at Johns Hopkins, who has written extensively on this, he was missing in action because he had contrary opinions as well. They published their guidelines. Guidelines of treatment and they are not standards of care. This was what came out in the Endocrine Throwaway Journal after the guidelines, where just saying, this is the new thing, you better hop on board because we've put these guidelines out for everyone to follow. The guidelines in a nutshell were: do a psychological evaluation, affirm and transition any child who insistently, consistently, and doesn't that sound trick? It's kind of a nice insistent, persistent, consistent. Whew, has a lot of poetry to it. If the child is that way, then you do what they want. Okay, has anybody raised a toddler? Okay, yeah. Are they persistent, insistent, and consistent? Absolutely. Drives us as parents crazy. But do we let them put that screwdriver into the outlet in the wall? Do we let them go and cut all the upholstery off our couches? No. We are aware that we probably are smarter than they are, but they sure are persistent, insistent, and consistent about it. So why would we apply that standard to this issue? So they say block puberty as it begins. Now this is a theory thinking backwards. These adults who went through the transgender process to try to change their persona, they didn't like the fact that as biologic males, they had broad shoulders, they had square jaws, they had a big Adam's apple, they were hairy everywhere, they had a low, deep voice. Okay, all that just doesn't make it easy to transition to the appearance of a female. So how could we prevent that? I know. Let's not make it happen at all. Let's block it before those hormones get into play. And then we can play with the body, with the other hormones, and we don't have to do all that other stuff like shaving the larynx and putting them on pills that block the effect of the sex hormones on the hair follicles. We can prevent all that by just not letting it start in the first place. What a great idea. Okay, let's block puberty in kids. Was there any science to that? Was there any ongoing study to show benefits versus risk over a long period of time? Zero. But it's recommended. At age 16, in these first guidelines, consider cross-sex hormone therapy. That was the Dutch protocol. Nobody waits to 16 anymore. This creates essentially a change in the body that was not expected by the biologic body, okay? The male XY cells in the body are expecting to see testosterone. The brain is expecting to see testosterone. The bones, the heart, the lungs are expecting to see testosterone. And if they see estrogen instead, it doesn't work. It doesn't fit. It's a piece of puzzle that doesn't jibe and doesn't get you back to the person you thought you were going to. The puzzle never fleshes out and looks whole as a result of that. And we do know from the long history of hormone action on the human body that there are disease states in biologic males where estrogen is accidentally overproduced. And all sorts of bad things happen. We have prostate issues, we have clotting disease, heart disease, and same thing, testosterone in females creates cardiovascular disease, causes cancers, okay? These are things that happen in the natural human state in disease, and we have treatments that have been developed for them to stop the damage because it is known to not work. It's not good for the human body. It creates bad things happening for these, shortens lifespans. So why would we then feel okay about taking hormones and not even raising the levels to just those disease states that exist naturally, but tenfold levels, and call that good health in children? Okay? So this is recommended, but without any scientific basis, and some concern that maybe some studies should be done to prove that it's safe and effective. At 18, if the patient desires, they can have corrective surgery. So of the 22 guidelines in this group here, only 3 are based on a moderate amount of science, and the rest are based on no science or very little science. How is that a standard of care? How is that safe? The 3 that were based on moderate science were, we don't know what's going to happen with puberty blockers, we should study it. Number 2, we don't know what's going to happen with cross-sex hormones, we should study it. And the other one was, we don't know about fertility, and we're concerned about, we know we're going to alter the fertility of that human being. We better consider talking to the patients about that. Okay, that is the basis of science for these things. And these were published, and again, they're quoted, and I have had judges and lawyers and legislators say to me, Dr. Van Meter, are you aware that all the endocrinologists have a different opinion than you do? Why are you the outrider with this wild fringe opinion that this is harmful when everybody else believes it's safe and effective, including Dr. Rachel Levine, who just stated so a couple of weekends ago? What are people supposed to believe when they're outside of the realm of what I know and what other scientists know? Okay, they're going to believe. Why don't you believe what all the 67,000 pediatricians in the American Academy of Pediatrics believe? What is your group? How many people are in your group at the American College of Pediatricians? And why are you the outliers? And I'll explain a little bit how that happens. So 2017, the guidelines were revised, and they lowered the age for cross-sex hormones therapy down to 14, and suggested that top surgery, so-called, that is mastectomies and taking out perfectly healthy breasts in teenage girls, could be appropriate. Okay. And they also removed all references to Zucker and ignored Paul McHugh's EPIC paper, which was published in the meantime between the 2009 and 2017 guidelines. And they ignored by the concerns of those of us. The Endocrine Society at least asked its membership, and I'm a member, we're going to publish these guidelines, we want your commentary on them. So I sent in commentary, and about 10 or 15 of my colleagues sent in their commentary, all of it concerned about what these things, and none of it was changed as a result of that. They didn't even recognize or didn't even acknowledge the fact that we'd sent in our concerns. So that it's a false pretense that this represents the entirety of the medical community, when indeed it's the guys on the committee who developed these plans, and they believe, they all agree with themselves. Isn't that nice? okay? But they don't represent the endocrine community or the pediatric community. And then the AMA comes in, they kind of say, hey, we like those guidelines, we're going to endorse them. American Academy of Family Practice does that. The American Academy of Pediatrics does one step further. In 2018, they published a guideline, and it was actually just a position statement that said everything that the Endocrine Society said, plus any kind of counseling for these patients is totally unethical. I mean, that just blew our minds. And within a week, there's a very, very intelligent, articulate psychologist, or I think he's a psychiatrist, from Toronto, who is a very, very strong advocate for the LGBT community. And he tore those guidelines to shreds in a beautiful op-ed that was published in a reputable peer-reviewed journal that said not only is that all nonsense, the idiot that wrote these guidelines, if he would look at his references to show that everything he portends is truth, is actually false. The American Academy of Pediatrics has not said a peep. Those are also referenced frequently as showing that all pediatricians, a la the statement by Dr. Rachel Levine, believe that this is the truth and the right thing to do. So everyone's being hoodwinked outside of the system. And how would you guys know if you didn't know what was going on? These are the two articles this is from the New Atlantis. This is a very limited circulation medical journal. It is peer-reviewed. But Dr. McHugh, I had an opportunity to meet with him before this was published, and he had written this treatise on the sexuality and gender findings from biological, psychological, and social sciences. He wanted to put this on the record that from his vast experience and his internationally renowned author and researcher, that there were some problems in the gay community with mental health that were not basically healed by maintaining that lifestyle. And the same thing for transgender, that neither of these were innate. And he said, this is going to be a bombshell, and I will be criticized for it, and probably it won't get published anywhere. I'm going to have one of my colleagues who's a bioethicist and a very strong LGBT advocate. I want him to go through this manuscript, and I want him to tear out absolutely any sense that I brought my Catholic faith into it, that it's based on any kind of unfair, judgmental kind of things. It's all pure science. And so Dr. Lawrence Mayer did that for him. And he said, Dr. McHugh, it's accurate and it's true. And you know what it proves? Is that the gay community is phenomenally underserved because of their mental health issues, which are blamed on society and not looked at as a primary problem in that community. The gay community is horribly underserved in terms of mental health because of the public perception that we are at fault, that we cause their mental health problems, when it is absolutely not true. I want to be the first author on this paper to protect you from criticism. And it was published, and within 3 days, there was a petition online that 600 signatures saying that this was a travesty, that it should be torn from the annals of medicine and burnt and never looked at again. I have not actually read every word of this. It is so dense. I have spent hours and hours going through and rereading and kind of digesting what's in this. There is no way that any one of those 600 people even turned the cover and looked into it. But they could condemn it within 3 days. So it's just phenomenal, the kinds of stuff that happened. But this is a very deep, it's like a piece of rich fudge. I wouldn't recommend it for you guys to pick up and try to read and understand. It is so technical, and the number of references in it is huge. And then there is Dr. Kenneth Zucker's experience with his 560 patients.
There is a synopsis of that.
There is? Okay. Yeah. So, as I said, not to be left out, the Pediatric Endocrine Society says, what they said, and on top of that, we should mandate that government mandate insurance coverage. Okay? So we've got all these professional societies not thinking on their own, but just, going through this. Now, how do these things happen in these professional societies? Well, here in the sort of the lime green color is the general membership and what they sort of perceive as normal. And up here is this little tiny oval of a special interest group, okay? So the special interest group talks to the executive committee and says, we want to put some guidelines together. And so the executive committee goes back and forth, and they look at these guidelines. The membership knows nothing. And then all of a sudden, the general membership is proclaimed to support what this tiny little fraction of individuals said. In the American Academy of Pediatrics, 30 individuals reviewed those guidelines. 67,000 members knew nothing. And yet that's called the AAP supports that as a result. So here we start out with the APA, like a domino effect on the AAP and the Endocrine Society, and boom and boom and boom and boom, and on you go. And before you know it, the international community, everyone on the face of the earth with a brain and a heart, believes that this is the standard of care and should be followed. So, how did this happen? Well, T came along with LGB, and T sounds, hey, this is a human rights situation. We can say it's innate, just like we believe same-sex attraction is. So we're going to invite you guys over to have our extremely powerful, highly financed network to get you on board and to get your goals met. What does the T stand for? Transsexual, transgender, transvestite, and heterosexual males and drag queens. Okay, so this last category is very interesting because sometimes they are gay males, but as RuPaul says about himself, and I had a picture of him, let me go back. His name is Andre Charles RuPaul, and he says, I'm not a female. I am a male, unquestionably, but I love doing this, and I love the acting and all that it belongs to. So this is, you would think that this is not actually anything to do with transgender whatsoever, and yet it's lumped in there. So advantage to include the T on the LGB is anchoring transgender as a civil rights issue, attempt to legitimize born that way, and a wider internet audience, and recruitment and grooming of new victims. And oh, the word grooming is a spark that gets the fires going against us. And for that reason, we try to use it as often as we can, okay? Because it is the truth. This is taking a otherwise troubled child and grooming them into something that we recognize medically and psychologically is a devastation to that human being. So that's our take on that. The U.S. landscape, transsexual clinic at Johns Hopkins established, kind of going back historically, the transsexual clinic at Johns Hopkins closed. SPAC's Boston clinic opens, the Endocrine Society guidelines. Now in 2022, remember there was one clinic in 2006 and 7? There are over 65 transgender clinics established at university centers, and the number keeps growing for centers because Planned Parenthood is now offering care at all of their facilities. And then there are some online services, one of which is called plume.com. You ought to look it up. All you have to do is chat with somebody online, and you will get your cross-sex hormones in a heartbeat. No physician visit, not even a physician. It can be a nurse practitioner. They are recruiting practitioners online at the same time that they're luring patients in. Hey, if you want to do this and get some extra money, do this online practice by telemedicine, and you can have some extra cash in your pocket, especially if you believe in this stuff and you really want to get around the back door. This is one way you can do it and get new patients treated. So 1.3% of children, by some studies, I heard a statistic, 2.8% of all children in the United States have gender confusion, according to the most recent study. Here's the map now of places. Remember that map from 2006 with one little place in Boston? There you go. Those are places in the United States that the Trevor Project tells you you can go and get your cross-sex hormones and your therapies. So the battle to return to science, only gender-affirming experts are invited to speak at academic meetings. I have been on the planning committees for the American Association of Clinical Endocrinologists, which is a smaller group than the Endocrine Society, which holds annual meetings every year. I was part of the Pediatrics Scientific Committee. We made suggestions, and I said, you know what it's time to do? It's time to have a dialogue. We need to invite a speaker who believes in the affirmation pathway for transgender children, and we need to have a speaker who does not believe in that and believes that the counseling process is the way to go. And we can we can look at the 80 to 90% success rate already established on that side, and try to show the data to the crowd who attend that meeting, and have a dialogue in the room, and have questions asked, and have the bogus scientific studies appropriately criticized, and the true science illuminated to the crowd who's present. So I suggested that. The committee said that we want to have that, and the meeting was in Houston. And as we were preparing, looking at the finalized program that they came up with, the program committee had a transgender talk with one guy from San Francisco who was pro-affirmation and nothing else. And when I heard about that, and I went back to our next scientific committee meeting and said, what happened? They said, we don't know. I mean, I guess what you need to do is to go to that meeting, and at the end of the presentation, stand up and ask some questions. And I said, are you kidding? You know better than that. It doesn't work that way. That's not how you do this. You need to be fair from the beginning, and that doesn't happen. Counseling to return to natal sex identity is outlawed in some states, okay? Very, very cleverly, this is what we are doing, is maintaining the biologic basis and identity for this patient, and we are called conversion therapists for doing that. Who's converting what? Okay? If you've got a biologic male and they want to have that person appear to be a female, you're converting that appearance to that. So conversion therapy, if it's actually passed, should ban everything that transgender affirmation crowd, I mean, really, okay? But that's speaking out of both sides of their mouths, and that's, they have it one way for same-sex attraction and another way for transgender. And they just take the word and they plug it in where they want, and the state legislators, in fear of being called bigots, just say, okay, whatever, we'll pass that. They also, they destroy the activists are very, very good at destroying opposition through academic influence. So a lot of these places, pediatric endocrinologists in private practice are a tiny minority of practicing ped endos. Most are at university centers, and their tenure is on the line. Their ability to have their articles published in research on any other subject is subject to the will of the program chairman, who, if the academic endocrinologist says, this is nonsense, this shouldn't happen, we should shutter down our transgender clinic for the time being until we can sort things out, that person is fired from the faculty. So there is an incredible amount of fear among my pediatric endocrine colleagues. And we talk, the vast majority of them think this is absolute abysmal medical care to do this, but they can't open their mouths for fear of being fired. So that's they're suspended from their positions for their opposing views. So they are pushing the opposition underground. The major medical journals refuse to publish opposition literature. All we can do is get letters to the editor. Rarely do we get any kind of article. One of the pediatric throwaway journals, which just is the pablum of the affirmation crowd, accidentally let an article through on stories of 4 desisters from adulthood who complained that this was the worst thing they'd ever done and warned everybody not to do it. It was like opening up and seeing the Bible again in front of you. Like, my God, this is the truth. This is everything that should be said over and over and over again. I never expected to open this newspaper and find an article like this in my lifetime. And here it was. So there are little chinks in the armor that are starting to form. There's a group called the Society of Evidence-Based Gender Medicine, SEGM. You should look them up because they are a reference, a beautiful, scientifically based reference group that has a broad clinical spectrum of politics in terms of the backgrounds of these individuals. But what we all agree on is that the affirmation from social to medical to surgical is an abomination for these children. It is the wrong thing to do. Not based on a faith base. However, faith may work through you to recognize that this is what it is. But these are some very agnostic individuals, human secularists that don't have any particular faith at all. They still see the truth, and they are publishing it, and they are making statements to legislative bodies. They're being used in declarations for state laws and whatnot to support the idea that this should not happen to children. So there are, again, these little chinks in the wall that are very, very helpful for us. So ethical guidelines for clinical research, just to tell you how things are done, and I've been involved in clinical research studies a whole lot in my entire medical career. You have to have informed consent. What does that mean? The patient needs to understand absolutely every detail of everything and how it will affect their bodies and their lives in the short term, and they need to be told what we don't know and what we might accidentally find out and the potential harms of going through the studies. So recruiting patients into studies is sometimes very, very difficult because they don't want to have a blank check of something that could happen to them, okay? But they go into these studies informed. The kids are not allowed to sign informed consent until age 18 in the United States. So if they're over 7, they sign assent, and their parents consent for them. There has to be, again, as I said, a clear assessment, absence of bias, presence in the balanced approach, and that's a balanced approach of what does the literature on each side show that we know going in that could be harmful or beneficial. An independent assessment of safety study is done as a safety committee, which is totally independent of the company doing the research if it's a drug, of the people who are on the study as principal investigators. They have what's called stopping criteria. If anything happens as a serious adverse event, then the study is halted immediately. And most cases not started up again, okay? So there is this safety mechanism. There's an institutional review board that goes over the informed consent with a fine-tooth comb to be sure that there is no wiggle room in that everything is explained. So that's that we have a currently funded NIH study, which you'll hear about, 4 academic centers in which established transgender clinics already treating patients. They got out from under all of the stopping criteria by saying we didn't have a protocol. We just collected data from these 4 centers who were pushing their patients through these transgender clinics. All we're doing is collecting data. We're not designing a study. We're just collecting data. And NIH funded that for 5 years. Now, what happens at 5 years? A lot of the transition patients are still in that bubble of feeling like they did the right thing. The bubble bursts at 10 years in after transition for a tremendous number of these patients. So studying something out to age 5 years to see how successful and beneficial it is nonsense. It should not be brought in as any kind of a criteria for saying that this is safe and effective. So there was no control group in this NIH study. They didn't look at kids who were not transitioned and compare them for their outcomes of mental health. And they evaluated the success of parents of the study by having the parents be the ones who looked at whether or not the patients were happy or not independent people who didn't know which arm of the study or whatever. This is all biased from the beginning. The details are not available on the NIH website about the funding for this or anything. You can't find it, but it's cited. Fallout in local communities. School boards are railroading through regulations without any public hearings. Large corporations are threatening to pull out of municipalities if the state legislatures pass laws that forbid the affirmation. Gender centers of excellence are actually treating patients from age 3 years and older despite the fact that there's no scientific evidence of efficacy and safety. So what can we do to turn to sanity? We always begin with a statement that truly shows compassion for suffering individuals. It surprises the heck out of everybody from the hostile press that comes to interview me. Gosh, you really aren't mean-spirited at all. That really surprised me, you know. And I said, I'm here. My job, my calling is to do no harm and to help patients through their suffering. And that's what I am dedicated to do. These are my clients. I take care of them. I have compassion for their suffering. Stand firm with our scientifically based convictions. Invite a dialogue instead of engaging in a war. We could very easily say, you miserable so-and-sos, you're biased, you're awful, you're rotten, you're taking George Soros money and you're funding it into here. And guess what that does? Nothing positive. So we don't play the game they play. We don't do the name calling. Some people might, but it's not effective. It's not the calling. It's not what we should do as compassionate, God-fearing human beings. We should treat the other folks as if we could change their minds and hearts if we explain to them where we come from. And that's how we try to do it. We join with a broad-based group of diverse backgrounds, the SEGM I mentioned, and never be afraid to introduce your faith into the discussion. When I was deposed by the ACLU and Lambda legal attorneys in the state of Ohio, Ohio is trying to fight against changing the gender or the birth sex to be the gender identity on birth certificates. And they said, for the public health purposes, this takes, health populations and mixes them up. You no longer can look at disease states that are germane to a biologic sex if you don't know what the sex of the patient is because the birth certificate has been altered. Population studies of disease over decades can't be followed because you don't know what the sex is if it can be just randomly assigned. So I was grilled for 4.5 hours by these attorneys from the ACLU and Lambda Legal. And at one point in time, they said, Dr. Van Meter, do you practice a religious faith? And I said, yes, I'm Roman Catholic. And they said, aha. Okay, what does your church say about transgender? And I said, well, the church teachings are that you love your neighbor as yourself. And so I love these children and care for them as if I were caring for myself, which is my calling to do so. And they just went, oh, crap, that's not the answer we wanted. We wanted you to say, this says so in our doctrines, and this is terrible and sinful and awful and hateful. And I just didn't give them that answer because I wanted them to know how my faith drives me. I'm not going to play a game where I can be quoted out of context, and yet my faith does drive what I do in my practice every single day. So these are some of the things that you got the lovely book today on the transition and detransition of an adult female patient. This is a book called, it's very cute, Trans World Airlines is the plane in the picture. For those of you who, there actually used to be an airline called Trans World. And that author is a male who transitioned to female, Renee Jacks, who's now back as a male. And then some of the other things that you can get online that kind of explain things. So it's high time that we point out that the emperor is naked. Thank you very much.